Good morning, participants. In this workshop, let me apologize because we had a little bit of a hiccup when we were just about to start. So some people have been waiting for quite a long time. So, but welcome. I'm sure we are now ready to start. We are second day of the Global Public Health Week, in which we are looking at the community engagement as a toolkit to equitable health and a means of fostering peace globally and in South Africa. In alignment with the Global Public Health Week, the Public Health Association of South Africa initiated virtual dialogues to discuss community-led health promotion, aligned with national strategies from April 8th to the 12 sessions. These sessions are going to focus on public health paradigms, global health governance, mental well-being, sustainable living, and developing healthcare competencies. These dialogues will feature keynote speeches. Unfortunately, we have a bit of a mishap today about the keynote. There will be panel discussions. We are quite grateful that we have panelists in our midst. We will hear about them a little bit later. I'll give them an opportunity to introduce themselves. And then we have got, most important of all, you as participants and our key stakeholders. For today, the focus is going to be on enhancing and democratizing the governance in public health. The issue of addressing health inequities globally and within nations surpasses health sector capabilities and national actions. It necessitates political solutions on a global scale, transnational norms and policies very often act as political determinants to maintain these disparities between nations and even within individual countries. We, fortunately or unfortunately, have realized that health issues have no respect for political boundaries or borders, as we have seen during the COVID-19 pandemic outbreak. But there, countries had to learn to collaborate globally. But we also saw during that particular time an example of how these inequities play out with richer countries getting into vaccines, and some of them even stockpiling them, while poor countries were not having access to that. So how do we enhance and democratize governance? Globally, of course, but also in South Africa, to reduce inequalities and foster peace. I have been privileged to be part of the South African response of the biggest pandemic that faces our country, which are HIV, STIs, and TBs. And for a very long time, these inequities have actually been playing out. For now, I can remember that when we were looking at themes that have been developed for various campaigns, we were looking at communities, the fact that communities matters and communities should lead. It also touched on the issues of resources as well, at a very greater scale of the distribution of resources. So hopefully by the end of this webinar, we will have put our heads together and come up with solutions out of various researches that people have done that could contribute to policy development in the country to deal with these inequities. Without further ado, let me take this opportunity to invite the panel members who are here to introduce themselves as well, one by one. I think we are supposed to have here Dr. Anam Nyembezi, Ms. Tsenolo Tshoaedi, Dr. Natisha Dukhi, Dr. Harsha Somaroo. I'm going to switch off my video for now and allow them to switch on theirs in that order. Over to you, Dr. Anam. Dr. Anam? If Dr. Anam is not there, Ms. Tsenolo? Oh,
yeah. You can't hear me. If you can't hear me, let me try something else.
We can hear you now. Who are you?
Anam Nyembezi.
Okay, please go ahead.
Okay, maybe the video does not want me to, does not want to work with the audio. Okay, if you can hear me now, my name is Anam Nyembezi. I am a senior lecturer at the School of Public Health, and I'm also the chair of the PHASA Special Interest Group in Health Promotion. Thank you.
Other panel members, please. I've said we should just continue in that order.
Thank you very much, Chair. Good morning, everyone. My name is Tsenolo Tshoaedi. I'm the Executive Director for CAOSA, which is the coordinating and membership structure of community-based paralegal advice offices in South Africa. Thank you.
Good morning, everyone. I'm Natisha Dukhi. I am a Senior Research Specialist at the Human Sciences Research Council. And within PHASA, I'm an ex officio board member, as well as the chair of the Advocacy Committee. Thank you.
Hi, good morning, everybody. My name is Harsha Somaroo. I'm a public health medicine specialist. I'm currently working at the WITS School of Public Health and Charlotte Maxeke Academic Hospital in Johannesburg. And with PHASA, I am currently an ex officio board member. Thanks.
Thank you very much, everyone, and welcome. In the absence of the keynote speaker, we are very excited that panel members will have more time, a little bit more time to reflect on their areas of specialization and make a contribution to this very important topic and matter that faces not only our country, but globally. I mean, I recall that in South Africa, the demand for communities for a very long time has always been nothing about us without us. And this has been a call by ordinary communities to be represented and be part of all the governance structures where actual decisions are being taken. And we do know that for a very long time, in terms of health, we have struggled with putting patients at the center of their health, or clients, as they now normally call it. And I think this is the time now for us to be able to reflect very, very seriously about these disparities. So I'm going to invite, first, starting with Dr. Anam Nyembezi, to do his reflections on this topic. And then I'm going to call on others as well. After that, we'll then be able to open it up for reflection, questions and reflections by participants in this webinar. So thank you very much. Over to you, Dr. Anam.
Thank you. I hope you can hear me now and you can see me as well.
We hear you very well. We can see you as well.
Okay, thanks very much. As I was saying, that I am a lecturer at the School of Public Health, University of the Western Cape, and I teach health promotion in public health. And we teach postgraduate students, and majority of them are healthcare professionals. And these are some of the issues that we often engage them with regards to this topic. And my reflections will be based on that because they come as healthcare professionals from different settings and in different parts of South Africa. And what we often receive from them is that there is an issue of inequity in the healthcare systems and in communities that they work from. And we understand that some of these issues have to do with the political determinants of health, and which are related to issues where government policies don't speak to the needs of the population. So in one of the things that we often discuss with them is that they think and believe that one of the issue about the continuing inequalities in the healthcare services is because we don't do much of the needs assessments for the communities, and we have policies and strategies that we develop and implement without having done a proper needs assessment for the communities that they work from and they live in. So a clinical example was about the COVID-19, where you find that we had good intentions as government, and we used WHO and other international standards in terms of how to prevent COVID-19. But you find that some of those issues are not relevant to the communities because of the determinants of health, and which means that people and populations are unable to prevent those kind of diseases and outbreaks. So we also find that also one of the issues that they talk about is about issues of informed decisions. So one of the issues that we should consider when we're dealing with these issues of inequity and how to make sure that we involve community members is to make sure that we use information. So our policies and strategies should be based on the information that we gather from the communities and are informed by those. And the involvement of the communities as well, it has been found to be an issue in the sense that they sometimes get involved in the projects, interventions, programs, but they don't have much to say. So their voices are not as loud as other sectors or other stakeholders. So that also needs to be addressed in terms of how they can also be given agency in terms of what are their needs. And then I think my other reflection will be about the issues of transparency in terms of the resources, because majority of community members, they do feel like that the resources that they should be getting in terms of dealing with their issues, there's not transparency in terms of how are they allocated to the healthcare facilities that they deal with them. So those are some of the issues that we encounter when it comes to that. But also we always try to advocate for them to be what we normally call that they need to be there's a need for an ethical governance in the healthcare facilities that they work from. So ethical leadership, which also tries to make sure that there's an understanding of the fundamental rights for health. There's an understanding of the importance of dealing with issues of inequity in their communities. And one of the strategies that we often engage them with is about issues of health in all policies, because as they are healthcare professionals, but we always encourage that they should be using approaches that in health promotion we think that they can be able to address those issues, because some of the governments, they work in silos, and there's a need for integration, there's a need for intersectoral collaboration in terms of dealing with issues of inequity, and we deal with some of those issues. But I'll end there for now, and I might add later my experiences in terms of the research that I work in, because my area of interest is on men's health, and I've been working in the Eastern Cape, in the rural areas, looking at the issues of traditional male circumcision. And it's one of those issues that have been neglected. It's one of those communities that have been neglected. There's lack of collaboration that is from the traditional leaders and people that are responsible for that initiation. And also there's a need for us to look into some of those issues, and we find that it is important to say, how can we best involve traditional leaders who are responsible for those issues. Thanks for now, Prof.
Thank you very much. Thank you very much, Doctor. I think very, very important issues raised. And I'm sure that I'm certain that the participants who have been taking notes, we will be coming to your input as well very soon. But for now, I would like us to invite Ms. Tsenolo Tshoaedi to do her reflections as well. Ms. Tsenolo.
Thank you very much, Chairperson. Yeah, I think from my side, my contribution will obviously be coming from the aspect of legal empowerment, and how legal empowerment is actually a very important tool if you are really intending to advance democratic values in a community setting, or you're trying to encourage community-led strategies, especially as it relates to health. So I work for CAOSA, which is, like I mentioned, it's the national coordinating body of community-based paralegal advisory offices. So these advice offices do use legal principles to address issues that are happening in communities. And one of these principles is obviously the principle of legal empowerment. And so just to give a highlighted definition of what legal empowerment means, it's according to the Open Society Foundations, legal empowerment is about strengthening the capacity of all people to exercise their rights, either as individuals or as members of a community. It's about grassroots justice, about ensuring that the law is not confined to books or courtrooms, but rather is available and meaningful to ordinary people. I believe that this principle of legal empowerment is also applicable in the health sector. I say this because I think my colleague who just spoke also just reflected quite well on the importance of having engagements with the diverse sectors or diverse groupings that are there in communities. I'll speak to a case that we intervened in. So during COVID-19, community advice officers were accredited by the South African Human Rights Commission to conduct human rights monitoring in communities. And one of the target areas for monitoring was around the community healthcare centers. And this was brought forward because of a growing need, or an identification of a need where health centers were not able to function as normal, and that was having a ripple effect on the extent of primary healthcare services in communities. In one of the community advice offices called the Lethabong Drop-In and Advice Center, which is servicing the community of Jericho, that is in the Northwest, just after Brits, you pass through Lethabile, and right there, it's a community that is still having a traditional council. And when we, initial consultations as you're doing monitoring throughout the community, we then got to know that there was an increase in rape cases emanating from women or young women and elderly women who were in line waiting for primary healthcare services at the community healthcare center. The fear there was that the community healthcare center was not opening as per normal schedule because of the lockdown conditions with regards to management of COVID-19. And because of the lack of information or the lack of empowerment by the community, that led to a situation where people were waking up at 3 a.m. to go and queue outside of the healthcare center so that at least they could be first in line if the healthcare center is operating. That opened them up to instances of sexual assault, of armed robbery, and endangerment of their lives. Because obviously that in that setting, there is no visible security that was on site where the clinic is situated. So that case came to us as more of a security question, a justice question. But when we delve deeper into it, as we do with regards to human rights monitoring, we noted that the issue there was around the community healthcare center not operating or operating in an erratic schedule. We then engaged with the matron in charge of the community healthcare center, and she was kind enough, or she was professional enough to actually indicate what are the challenges that are leading to the healthcare center not operating, or at least not even communicating the hours of operation to community members. And she indicated that from time to time, they would arrive at the healthcare center and there would be no water in the facility. So if you know Jericho, you'd know that it falls under the Madibeng local municipality, which is in Northwest, which actually falls under the major district of Rustenburg. From that intervention, you are able to link challenges that are happening at a budgeting level. You're able to link challenges that are affecting the functioning of community healthcare centers right back into communities with regards to justice and safety issues. And so we learned in that process that monitoring, especially human rights lensed monitoring, became a crucial way in which we were able to identify what are some of the drivers of not only the lack of access to primary health care, but also other social issues that were then become prevalent in the community at that particular time. I think this case demonstrates the need for empowerment. And this empowerment should not be one-sided. It should not be empowerment that is just directed to community members. But there's also a need for healthcare professionals to also be empowered. The nurse did not know that she could, as a professional, lodge a complaint with the Human Rights Commission to say that she, as a professional, her human rights are being infringed in terms of how the engagement with the local municipality around the provision of water was actually affecting her own safety and her own health in that particular case. And so obviously, the clinic would be closed simply because when there's no water, it becomes impossible to then open up services for people in the communities to actually come in, some of whom are sick and some of whom require medical attention. And that without water, it becomes a dangerous setting for a healthcare professional. And so in that instance, you identify a human rights violation in terms of the patient, but also a human rights violation in terms of the medical professional as well. And so we learned that, human rights monitoring, especially, implementing it with a empowerment lens, becomes quite important if you are looking at making sure that health services in communities actually become democratized. So I just wanted to give just that example of instances when we saw the importance of legal empowerment, and not legal empowerment that is only just directed to patients or community members, but also to healthcare professionals that are working in those health facilities as well. I think I'll just pause there, Chairperson. Thank you.
Thank you very much. Yeah, you got me thinking, Ms. Tshoaedi, as you were talking on legal issues. In the particular sector where I'm involved in the HIV and TB space, there are legal issues pertaining to stigma. And we do know how much stigma has actually stood on the way of us strengthening the response as a country. And we have been looking at issues of human rights, especially pertaining to stigma, but I do think that it does apply also to many other health issues. And as you were reflecting on this particular facility, maybe, Ms. Tshoaedi, the problem is that people who are policymakers are not impacted themselves by inequities. Very often, if you ever become a policymaker, it means you have graduated. You have, even though you might have grown up poor, the moment you become a policymaker, it means you actually have jumped and been part of the privileged. And very often, our thinking is shaped by the context within which we live, and we forget the life situations of other people. So, of course, the issue of the legal services accessible to everyone, it's such a big challenge overall, because of the way that very often legal services have also to do with money. You know, the more money you have, the more access you can have. But thank you very much for your reflections. I'm sure that participants will be able to come in and make inputs and share their experiences as well. I would like to invite, therefore, Dr. Natisha Dukhi to also share her reflections on this very important topic that we are dealing with, looking at the enhancing and democratizing governance in global health, also particularly in our country, in South Africa. Over to you, Doctor.
Thank you, Reverend. Thank you so much. I think my reflection stems from my work, that I do with impoverished communities, especially with adolescents. And so it speaks to the fact that when we look at governance and when we look at, changing strategy and changing policy, it comes to the fact that often enough, when we talk about inclusivity, are we really inclusive, of communities, of the participants that we engage with? And so often enough in impoverished communities, we go in, we want to do a form of research, it's carried out and we leave. And once we leave, there's not much that we offer to that community. There's no level of empowerment, or sometimes very little at the start. And we forget to think about the fact what happens to them beyond that. Also, falling back on what the previous panelist said, looking at it through an empowerment lens. If we have to consider that, especially in impoverished communities, we would have to be looking at capacity building. Are we building people within these communities up in whatever ways we possibly can, even before we do some kind of intervention in there? Are we tailoring the programs, making them specific to the different targeted groups and for targeted intervention? Adolescence is a very unique group. It doesn't fall under children, neither is it part of adults. And yet we have policies in South Africa. And if, people are familiar with some of the policies regarding the, obesity, nutrition, previously we did have policy that was, very much focused on adolescent. And now it seems that this vulnerable group falls under, a very different feature, which it goes under youth. And we know that, again, there's a problem with that in the sense that youth in South Africa is different from how we define youth elsewhere. We have an extended version of youth that goes beyond 24 years and goes right up to the age of 35. But then if we are looking at people from 15 to 35, what about the people who are adolescents from 10 to 14, for example? Where do they fit in? And how are their needs, action? So it's very important that when we reach communities is that we involve them from the very beginning. They are actively involved. And we have to look at, with that empowerment lens, we need to look at what are the barriers that are there already. We cannot go in, wanting to do a certain part of research that we think is relevant and that we have read through literature without having engaged communities to find out that maybe something that we considered very much important to have interventions for might not necessarily be the first three things on their list. It might be further down the list for them. And therefore, we need to look at part of that empowerment lens is that we address some of those barriers, or how do we incorporate addressing those barriers as we go along and assist those marginalized communities or impoverished communities, especially in terms of healthcare and healthcare services. And in terms of policy development, I think at the get-go, before we even talk about policy and strategies, we need to ensure that when we are looking at these groups and we are wanting to make decisions for them, that if we speaking about inclusivity, we include them from the beginning. We find out what their needs are, what their barriers are, how do they want things to work in an ideal situation for them, what can we offer, and what are our constraints on that matter. And also bridging those gaps between community and other stakeholders is very important, because once those relationships are fragile, it's going to give us a very different perspective of how we engage at a policy or strategy level. So I think there needs to be inclusivity, there needs to be participatory processes that take place from a diverse range of stakeholders, and that needs to include people from rural settlements, informal settlements, impoverished areas, and those that we have to take into consideration greatly of the age groups that we are working with, and that there's no blanket effect. We've heard someone say this yesterday's session. We can't work within a blanket effect. That doesn't work, especially if we are wanting to strengthen governance. In order for that to occur at the very top level, we need a bottoms-up approach, and that bottoms-up approach means that we need to work at the level of the people that we want to provide solutions for. We need to work with the people that we want to develop interventions for, and we need to work with the people that we want to develop policies and strategies for.
And see if they're giving us the medication.
I think I'm going to stop for there now, Reverend, and I can always follow on this discussion from then further on as we go along. But I think I just want to highlight, yes, the inclusivity component and the gender lens when looking at communities, especially impoverished communities, and how we go about working with them before we even get to the level of policy and strategy development.
Can I ask participants to mute or be muted? Mpotau, Noktula Kumalo, Sikola TF. Can you please mute? You are with us, you are not with us, because there is a lot of noise. Mpotau, can you please mute? We just have another hour, and let's make sure that we invest in this time and we focus on it since we are here. Thank you very much, Dr. Natisha, for your reflection. I'm going to move over to the last panelist, Dr. Harsha Somaroo, We have at the moment here 57 participants. I think that includes all of us. And I'm sure we are in for a very interesting conversation once the panelists would have reflected. There are questions that we should think through as we reflect. And I will, after the input by the last panelist here, I'm going to ask that those questions be read very slowly to all of us, so that we can be able to be a little bit more focused. So over to you, Dr. Somaroo.
Thanks, Reverend, and good morning, everyone. I think when I was reflecting on the topic, I thought about what are the intersections between democracy, governance, and for our group specifically, public health. And I think if you have to really summarize that, it's about having transparent and accountable systems that promote inclusive decision-making, where we involve everybody. We involve multiple stakeholders, not just the government. We involve civil society, we involve communities, we involve healthcare workers as well as a specific group, not as part of other groups as well. And I think Tsenolo reflected on the role of communities, but also how healthcare workers need to be empowered to be able to engage better with legal processes. And I think that's important to reflect on when we're looking at these intersections between democracy, governance, and public health. I think knowledge is power, and we really do need to empower people to understand what their rights are, so that they become more engaging and accountable citizens, and they really function as part of the democratic process in the country. And this really happen at all levels. It starts with the highest legal policy in our country, from the Constitution, and goes all the way down to the policies that we implement within our public health sector. I think we need to capacitate people understand these policies better. We need to invest in training for citizens as well as for healthcare workers. And I think also for people who are involved in the policy-making space and our elected officials, I think everybody needs to have formal policy training and to understand what policies are, all the different levels, that they can implement it better than we have been doing in the past. I think there's always room for improvement in what we do. And I think, the best way to actually achieve what we want to, I think Anam also reflected on how we have really great policies in South Africa, but implementation is not always as effective in all settings. And I think one of the great ways to improve on this is really to build capacity, and that capacity building needs to happen at all levels, so that people really are engaged and work better in terms of, one, understanding their rights as South Africans, specifically when it comes to their rights with regard to health and healthcare in the country. And then also at a lower level, at the individual level, we need to focus on health promotion. How do we implement policies better so that we empower people to take care of their own health? Because I think improving the health outcomes is part of the entire cycle of improving health policies in the country and being able to provide better even at the higher policy level as well. So I think, my main suggestion today for really improving these intersections between democracy, governance, and public health is, one, to really focus on capacity building at all levels of society, from the government all the way to the individuals in the community. And I think this is really going to empower multi-stakeholder engagements, and it's going to really empower South African society to really work better together to improve what's been happening so far. I think collaborative governance approaches where we are inclusive and we foster dialogue and partnerships between the government and people will really serve to improve how we move forward in a democracy, and also in terms of eliciting better public health outcomes. So I think I'll stop there, Reverend, and hand it back to you.
Yes, thank you very much. I think from when we look at the topic, when we look at health governance, in South Africa, I can think of particularly two governance structures which go down to community level. One is in terms of the Health Act. You have got various health councils, which are in terms of the Act, going down to hospital boards, clinic committees. For the participants, I think the idea there is to try and make sure that those who receive services are part of decision making. But are they working? Maybe some people who are here on the panel might assist us. Are they working? If they are not working, why are they not working? I'm part of the South African National AIDS Council. Part of my responsibility is to support governance structures for HIV, STI, and TB. We call them councils. They are supposed to go down at least to ward level. My experience over the years, I always call it that when it comes to governance, it becomes the law of diminishing returns. So the structure is okay at the national level, starts to be wobbly when you go to the province, district, west, municipality. When you come to a ward level, there are very, very few wards which have got wards 8 committees, even though a particular ward will be suffering from the burden of that particular virus, if it is HIV, or the burden even of the triple pandemics. Why is it? Why is it that we have got the law of diminishing return? Why is it? There are few countries which, in terms of literature, we know are very strong at the local level. I've heard, for instance, of a country like Germany, and little wonder that they seem to be really make a lot of progress, even in various areas, because they do focus on local governments very, very strongly. That's where you are closest to the people. So before I ask for the other questions to be read, I would like to pose this question of, for the participants, who are the governance structures that we have working in terms of dealing with all these inequities, in terms of making sure that ordinary people participate. Lungile, Roxanne. Lungile, Roxanne. Please, participants, let's not be rude. Let's just make sure that we are actually, we mute, and then our webinar will go very well. So I'm going to ask Professor Takalani Tshitangano, she has raised a hand there, to come in, and hopefully you will also assist us with some of the questions that we need to reflect upon. Thank you.
Thank you, Reverend Chairperson, for this opportunity. I'm not going to have my video on, so I'm just going to go straight to the question and the input that I want to contribute. Mine will specifically be looking at cancer services. So when I look at cancer services, it makes me reflect on the health system structuring as a cause of the disparity. I just want to give an example of a PHC facility, a district hospital, and a provincial hospital, how they operate in terms of cancer services. What happens in the PHC facility is that a nurse will identify a tumor and not know whether this tumor is malignant or what, and then will refer this patient to the district for the district hospital to do some test that will diagnose whether it's cancer or not. And if it's found to be cancer, this patient, because the cancer treatments are not instituted at the district hospital, this patient will have to be transferred to the provincial hospital for treatment. And most of the time, this process delays. It delays either diagnosis, it delays treatments, because they will be on waiting list for months. And at that time, the cancer itself, it's getting worse and complicating to metastasize to other parts of the body. So my question is, what and how best can we democratize our health system structuring and governance to ensure, because these people have the right to health, to ensure that they receive their health, which is their right, at the proper time, which is what we want to see in South Africa. Both the civil society, what is their role in this case? What is the role of the policymakers? What is the role of the community? Maybe Tsenolo will also assist. So my question is, how do we democratize governance to ensure that our people do not receive poor quality health service in the process? Thank you.
Thank you very much, Prof. I think it's time now that we should open to the participants. People are many, so try and be brief, but we have a bit of time, just under an hour, to have a conversation and to round it off. When you introduce, when you speak, please raise your hand. I recognize you. Introduce yourself, what country you're from, if you're not from, and also you can share with us a little bit about what you do. That will be quite important. So may I please open it up for participants to come in. I'm actually scrolling down, and may I also ask other people to assist me, those who are like Professor Takalani, if you can assist, if somebody raises their hand. Any?
We have Prof. Natisha Dukhi. I think she has been given the rights to do that. She will assist. Thank you.
Okay. Thank you, Prof. Prof will assist me with that. Participants, it's all yours. And I'm going to then, while the participants are still thinking through, allow the panelists, after having listened to the others, if you want to take another bite, please come in. And just raise your hand as well as a panelist. So Tsenolo wants to take another bite. Thank you very much, Tsenolo. And also Harsha. So let's start with Tsenolo and Harsha. And participants, please get ready. Oh, there are more names now. So wonderful. Let's start with Tsenolo, Harsha, and then Sbongile. Over to you.
Thank you very much, Chair. Thank you. I think I just wanted to, before I lost my track of thinking, wanted to just talk about the issue of stigma. I think it's been an ongoing challenge to address. We saw it raising its ugly head during COVID-19. If you'd recall, initially, there was false information that was being spread in communities about the existence of COVID-19, simply because measures that were being put in place were not immediately adopted, even in rural settings. So you had a lot of social distancing and other measures being implemented in metropolitan areas, urban areas, but not the same level of interventions happening in rural communities. And so what that created was sort of like a disconnect. The reality of how COVID-19 was actually impacting urban settings and rural settings became quite different. And we then also saw how, community structures are actually quite vital when you are addressing the issues of stigma. I'm speaking specifically about traditional customary structures within communities, like your traditional councils, like traditional healers for that instance, but also the religious and faith sectors as well. We do know that, a lot of people opt to go and seek treatment or prayer instead of treatment. We do know that a lot of people opt to go and consult because they are attaching a physical ailment to a spiritual challenge, and not wanting to cancel the effect of one's spirituality on their health. But I think it's also another area that is actually quite critical, that has played quite a big role in terms of addressing the issues of stigma, or to a certain extent also contributing to them. And I think there could be a lot of strengthening at a community level. I like that that example that you made around how efficiency dwindles down the further down you go. So from at a national government level, it is quite efficient. There's high-level conversations happening, and there's plans that are being made. But when it comes to implementation and when it comes to community engagements, that becomes almost non-existent. So I think it's also one of the ways in which we could agitate for stigma to be addressed is active understanding, collaboration, and partnership with these sectors that are there, that are highly, highly influential in communities as well. I wanted to just also respond to, I think, one of the comments that was made in the chat box around disempowerment, systematic disempowerment, that is. We know that our education system, we know that language is quite a huge challenge. You want communities to participate, but the language at which we are addressing certain issues immediately takes them out of the conversation, because now you are approaching it either as a legal professional or as a healthcare professional. You might be, using jargon that community members don't really know or don't even understand what that means. And I think that one of the challenges that we have in this country is that the health sector is actually one of the sectors that display the extent of inequality in this country. Once you move from a certain economic level, then public healthcare services become almost shunned upon, if I can say. And I'm wondering if perhaps there should also be a conversation that we are possibly looking at to say, are these professionals that come from poor communities and then, raise up through the ranks and become somebodies in communities, and they are able to afford private healthcare, are they not actually in a better position to actually contribute to the improvement of public healthcare services? I also just, my last point, Chairperson, I also just noted that, in terms of the SDG 16, number 3 is good health and well-being. And I'm wondering, is there not an opportunity for a structure such as the association that has invited us for this webinar to actually do a shadow report on the extent of health and well-being, particularly around the systematic governance related drivers that are actually affecting South Africa's ability to become a good contributor to a sustainable development goal around good health and well-being. Are we utilizing some of these opportunities to actually bring forward the conversations around the need for systematic reforms, especially at a governance and I don't think we have a policy level, a policy problem. I think more than anything, we do have an implementation problem. We do have a political will problem. And I'm wondering if some of these international and global mechanisms that are there that are meant to bring some level of accountability and evaluation, if we could use them to actually showcase and to actually demonstrate where the system is working and where the system is not working, and what our input would be if ever there is to be transformation and change that comes, especially at a systematic level. Yeah, thanks, Rev.
Already making, I'm sure PHASA is noting some of the recommendations you're making there about the schedule report. I'm going to ask Harsha, please come in.
Hi,
After
thanks, Reverend, and thanks, Tsenolo. I think I'm really going to build on what you were saying, because I also wanted to respond to the comment on the chat. I think it's a very relevant comment about one of the challenges that communities face, in that they have a systemic learned empowerment. So it really does limit their ability to be change agents for themselves. And the question is, how do we move from speaking for communities to communities speaking for themselves? And I think we've got to answer this in context. I think there is a role for speaking for communities. I think us as health advocates do need to speak for vulnerable populations, and we need to continue to do that. However, it is increasingly important to empower people to take control of their own health and to have their voices heard as well. And I think it goes back to what we were speaking about before, health in all policies, looking at the education system and how is health issues included in the curriculum, so that how is policy making included in the curriculum, and how is engagement, participatory engagement from communities included, how is it taught at school as well, so that we can really develop responsible citizens from the time they're young. And I think another comment I wanted to make about that is, I think as much as I think it's important to speak for communities, it's important for communities to speak for themselves, I think the one other thing we want to really achieve is how to speak with communities. So we do need to create inclusive platforms. I think the Reverend alluded to some of the existing platforms before, and he asked the question, why are these not working in all settings? And I think we really have to focus attention there to really make sure that these spaces for engagement of people from all levels are more active. And that really means, like Tsenolo had said as well, it means prioritizing these. It means having more political will to achieve this, and hopefully during an election season, people can raise these issues, and hopefully politicians will respond. Thanks.
Thank you very much. We go to Sbongile. Please keep those hands coming. And if you have spoken, you just drop your hand. So we now have Sbongile and Yvette. Let's start with Sbongile.
Good morning, everyone.
Don't forget to introduce yourselves. Thank you. Thank you, Sbongile.
Good morning, everyone. My name is Sbongile Ntamo from an organization that is called Women Believes Connections in Bloemfontein. We are a community-based organization. We work with the community, linking the community to care, advocating for the rights of the patients, conducting dialogues around health issues, TB, HIV, and everything that concerns health. One of the issues that, as a member of the community in Bloemfontein, that we've experienced is that people move from their healthcare facilities near them to go to a far healthcare facilities because that they say that the services provided in the nearer facilities, it's not up to standard. And therefore they opt to move to a further facility to get care, and which makes them go there for more days, like 2 days, seeking help, and it becomes a problem. And also they have to spend money health care facilities to be the same, that so that services, they can be able to access services without going to far places. And the other thing is that they say that sometimes when they go to those facilities, there is a shortage in medicines and things like that. So if we can maybe just look at the resources, how are resources shared in all the facilities, it would assist the community, and it would assist with all those who default from their treatment. Thank you.
Thank you very much, Bongile. I'm sure that the other participants will respond and even amplify the issues that you've raised. It's quite real. I mean, in most of the rural facilities, when you talk about shortages of drugs, they are the ones who experience it first severely. I do know that people living with HIV and AIDS have got a massive program to monitor various health facilities in terms of the level of services that are offered, not just to people living with HIV and AIDS, but in general. And maybe in the future we'll have a bit of a reflection on it, but I see Mukhadi is here from SANAC. Hopefully, Mukhadi, you can share a little bit, some light on what you are doing on that side of SANAC in terms of this topic of moving closer to equity or equitable distribution of resources. We will ask Yvette now, and I will ask Natisha to drop her hand, unless I think it is, it's a historical hand. So I'll give this opportunity to Yvette. And I'm trying to scroll down to see other participants who would like to speak. I don't see any other hands. So we're going to ask Yvette. After Yvette, I'm going to ask Mukhadi for a reflection. Yvette?
Thank you so much.
Mohammed. Yes, Yvette.
Thank you. I'm Yvette Zihalirwa, and I'm coming from an organization called Eat Better South Africa. We operate across the country in communities and clinic. And our main focus is empowering communities as a whole with nutrition education. So has a first intervention approach to a non-pharmaceutical care and management of chronic illnesses and better health maintenance. And one thing I want to echo what was said by Tsenolo in terms of that we have an implementation problem. And one thing we've learned in our space operating in clinics and operating in communities, that we found that a program or a particular program is needed. But because there is existing program that whether it's by the district or municipality, once there is a program that has been adopted by that said district, it's always very hard to bring in new or innovative interventions. You find that we struggle to get program in, even though we know that if a program worked for this particular community for the past 5 years, food patterns are constantly changing, markets and inflations and costs are constantly changing. So these things were not taken into account when that program was initially introduced to a community. So when you bring in new programs that's actually responding to the current community problem or issues, you find that it's very hard to get the support from existing structures. So the implementation of this project, it's going to be embraced by the community, it's going to be embraced by those it's benefiting the most. But from the structural level, from the system level, it's very hard to get this program implemented or get the support it needs so it can reach those it was intended for. So I do echo those shadow reports. So if something is being put into the radar of the policy implementers and the advocates that are advocating for community, that will be something that we can then pick up from these shadow reports, not just focusing on, oh, this is the report of the project we are implementing. This is how it's doing. It's still doing well. But then what happened to the evolvement of the community, the growth of the community? And another thing is that once a community has been blanket identified with one particular problem, you find it very hard for them to move over to maybe there's 2 more problems that were overlooked during the initial survey or the initial implementation. So that shadow report is something that's going to help the system, something that's going to help every community to pick up to those things that we often miss, or a smaller project that's making really, really big impacts. That's all.
Thank you very much. I had recognized, let me see quickly, Mohammed Ishak, the Thai. After Mohammed, I don't know, Mukhadi, are you still around? I really want you to, you have been battling with this topic of inequalities in health, Mukhadi. You, as part of the research sector of the SANAC Civil Society Forum, you have really been battling with this, and I'm sure you can share your experiences here. I don't know if Mukhadi is still there, but let's first go to Mohammed.
Thank you so much. Thank you so much. Yeah. Just from myself, my name is Ishaq. I lecture in health promotion, and we have a number of projects around Cape Town, and you know I've been involved in community development for a few years now, and the one observation is that although we don't have apartheid in policy any longer, or we still see the structural effects of apartheid very, very strong in our communities. And what apartheid did was it separated out communities of different kind of races. My observation post-apartheid is that we have what I call an economic apartheid. What happens that people in different communities, there may be upward mobility, and you find that the people with skills move out of the impoverished areas. And I mean, you can't blame people because, there are major challenges, including safety and security. And so people want to find a space where kids can grow up more safe. But what I'm finding is that it leaves quite a big vacuum for the people that are behind, because often it's the young people that have gotten some kind of leadership skills that now move out. And the challenge that I'm finding is that there are not many people that are coming back to the communities that they grew up in. So we find this big kind of void in leadership in communities. And it's a big challenge, I think, you know. So the question is, you know, how can we look at that? How can we, you know, what apartheid did was it separated out communities and it created othering of between people. So, you know, can we look at ways in which we can get people from different backgrounds and different professions to be interacting with each other or working towards community change? Because, you know, if we're thinking about democratization as such, you know, we run lots of different, we do needs analysis and we do lots of vertical interventions, but I don't think that there's enough kind of bottom-up interventions that's happening. And even from a political perspective, I mean, if you think about it, 30 years ago, we had like street committees. Democracy really felt like democracy then. Now it feels more like, you know, every few years, political parties go around and they're canvassing within areas, but very little leadership coming up from the communities themselves. We are busy trying some approaches, you know, which we're calling Ubuntu approaches, where we're trying to get people from different communities, different backgrounds, to go and interact with each other on a weekly basis and just basically form connections and see what can happen from there. And I wanted to know if there were others had similar kind of experiences of you know, trying bottom-up approaches towards changing things. There were lots of comments that were made about how efficient we are at a national level, but how these things don't filter down at community level. So, you know, I'd like to hear about, you know, other people's experiences around, you know, trying to democratize communities using bottom-up grassroots approaches.
Yes, thank you very much. It's such a challenge. Mel or May, you have your mic on. Hopefully you want to speak. Otherwise, please just mute it. If you don't, you have no intentions to speak. This bottom-up approach, it's such a challenge, especially in South Africa. I don't know in other countries. I travel a lot in the country, a lot, because of my job. I don't remember ever getting a pothole on a national road. I don't remember. And I'm really traveling extensively. But the situation in local roads is quite different in municipality roads. So the country seemed to have a lot of capacity to build state-of-the-art roads. And I can tell you that I have driven in other continents, in the US, in Europe, in very developed places. Our national roads are amongst the best you can even think of. You can think they are the autobahns in Germany. But that capacity is not being felt by the people. When you go closer to where people live, that's where you start to have these problems of poor quality workmanship. So the bottom-up approach, apparently, it's not only the problem of a health issue, but overall. So it's something that we need to reflect upon and find solutions moving forward. So Mukhadi, please come in. And then after you, I'm going to open this to Anam Nyembezi. Mukhadi?
Thanks, Chair. My name is Mukhadi Malasela, and I'll come from the South African National AIDS Council Civil Society Forum. I'm leading the NGO sector, or NGO sector as others call it. I think the issue of, inequity in our society is really, it's tragedy in a way. There are so much imbalances, even if in the NGO arena, you find that there are so much imbalances that it really for me it's tragic, because you find that those that are actually doing a lot of work on the ground, one, if we're talking about organizations that are providing services, even health services, the organizations, your community-based organizations, they've got so much commitment in doing what they can. And I'm saying in doing what they can with limited resources, trying to leverage on whatever is available on the ground. But when you look at in terms of the source of funding, they are the least considered. Number one, because they will be told you don't have capacity. Number two, you don't have systems in place. It will be those things that are more looking at, you know, what's the funder or the source of rather than come in as a partnership, even with big organizations that are NGOs, that are non-governmental and small community-based organizations. There is so much imbalances, and there's so much, you know, problems in terms of resources. I'll give an example of a big organization that is working. I'm not even going to go internationally. I'll talk about working at national level in South Africa. You will find that when they have to go into a particular district, they would need a community-based organization to actually get through there in terms of consultation, getting your memorandum of understanding, being able to work on the ground. But when it comes to resources, those organizations are not being looked into. A big organization can get a lot of funding to go and work in Umgungundlovu, in KwaZulu-Natal. When they don't have the funding, they move out. A small community-based organization that doesn't need a lot of resources will work in that area. Whether there's funding or no funding, they will still continue working. The second one is where, if it's a big organization that is working there, they've got all the systems in place to be able to capture the data and information that they can be able to share. Whereas our own organizations, it becomes difficult for them to actually get into any system to be able to actually work in that. And for me, it's those imbalances, those very simple imbalances that are actually tragic, because they on the ground, as community members, when we are providing services, we actually have to look at everything. I cannot go there and say, they said I must go and do you know, TB screening, therefore I'll stick to that. I'll still have to look. If I find that there's a problem with a child in that household, I'll be able to try and solve that problem. If there's someone that's being abused in that household, I'll still be able to be the one that assists the person, run around, try and get to you know, report the case and all that. So our work on the ground is more intensive, and there's more you know, there's more will to be able to do the work. We might have not had as much capacity as bigger organizations, but we do need to really make sure that there's a balance between those that have high-level technical skills and on the ground. I think from the NGO sector, we have partnered with Best Health Solutions a number of times. I'll give an example of where we really realize that it's not really more that they cannot do what they do on the ground in terms of community organizations. It's really more of how far they can go. We worked with one of our responsibilities is building capacity of organizations to really be able to run their programs effectively. And last year, during the AIDS conference, we worked and with organizations, submitted about 108 abstracts to the AIDS conference. 54 of those were actually approved, coming from the community-based organizations that don't have any resources. 22 of those were actually more, were oral presentations. And for me, that was such a highlight to say that there's so much information on the ground. We go to these international conferences, we listen to people talking about our own communities and telling us what's happening there, as if we cannot talk for ourselves in terms of what's happening, as if we cannot co-work with each other, complement each other to be able to actually occupy those stages. And even with scientists that are, or researchers that are doing, you know, all these researches and coming up with reports, more often than not, there is not a space for communities to actually start listening and challenge some of the findings that are coming from there, or giving more insight, or giving more context to what is happening. So I agree with Mohammed. There is quite a critical need to start from the ground. Because if you look at communities, they're not saying, when you come with a certain expertise, we don't want you in our area. It's more like, let's work together, but also capacitate me, so that when you move, there is sustainability, there is consistency in terms of what is happening. So yeah, in terms of democratizing, I think we need to really start looking at that. I'm sorry, I didn't start with the session, so I'm not sure what other people looked at democratizing, you know, issues, what it really means. But for me, it's more of how do we really enhance what's working on the ground and leverage on that to be able to be efficient, and also make sure that those that are on the ground understand. We take our communities with us, we move with them, and make sure that they understand what the work entails and what needs to happen, so that there is sustainability along the way. Thanks, Chair. I hope I've sort of like also contributed a bit in my understanding of the topic.
Yes, thank you very much. May I please invite Anam, Nyembezi? And I'm trying to see other hands. We don't have another hand, is Anam. If there is no any other hand after Anam, I will revert back to the, okay, there's Mohammed as well. Okay, so Anam.
Okay, thanks. No, I was gonna echo the same sentiments with Mohammed, and just to say that another lens that maybe we can also use is decoloniality in terms of like trying to ask the fundamental questions, because we should understand that some of these approaches and programs and policies do not address the distal determinants of health. So they don't look at issues of racism, social exclusion, apartheid, and the likes. So they in a sense entrenching exactly the inequities. And I mean, you fail to understand that in this day and age, you will still have hospitals that have no access to roads. So you'll find that there are hospitals, clinics that don't have the resources. It's because the issues that should be addressed by the policies and the programs that we have don't address those issues. And it's very important to think about how we can have these policies that look at, or these approaches that are trying to remove the structural barriers and empower the disadvantaged population. And these are some of the issues that we need to think about also in terms of when we think about collaboration. You know, working together does not automatically translate into collaboration. And these are the things that we should also think of. Do we have to think of co-design, co-partnership, co-learning, those kind of concepts which are trying to make sure that we all sit together and contribute towards the health of the population. And an example will be, if we look at our rural communities, there is no collaboration between traditional health practitioners and biomedical health practitioners. There is no co-learning, there's no co-design, there's no co-creation, there's no referral, but we're dealing with health issues here. So if we look at we use the decoloniality as an approach, we will consider instances where we see whether we can leverage and establish those collaborations for the benefit of the population. I've made an example about how frustrating it is to be in this day and age, still have deaths that are related to traditional male circumcision. And in this day and age, you will expect that traditional leaders will be part of the solution. Traditional practitioners will be part of the solution. Government will come up with programs that are intentionally responding to those issues and capacitate, and not only empower to build autonomy, because sometimes you find that in their own initiatives, as they empower, but they don't give them that autonomy for the sustainability that Mohadi spoke about, because it's very important for government to think about those issues. And lastly, the issue of there's an approach called gender transformative approaches that we also look, and it's very key in terms of dealing with programs and interventions that are aimed to reduce. Recording in progress. Because it's those issues that we just look at peripheral issues, but we don't look at the structural issues. We hope we have issues of teenage pregnancies. We think that we can deal with issues of teenage pregnancies, but we don't look at what are the structural issues, what are the fundamental issues that contribute to those issues, and how do we engage and co-create with teenagers? How do we engage boys and not only focus on girls in terms of dealing with those issues? So some of these issues can be also looked into those issues. So I wanted just to echo the issue of apartheid and coloniality and that Mohammed spoke about. Thanks.
Thank you very much. May I please move over to Ishak, then Oria.
Yeah, thank you so much. I mean, I think, there's some very fantastic points that are coming through. I mean, the one big challenge we've got with regards to bottom-up approaches is funding. And so, I mean, I think that Prof. Takalani, she made a good point here about Tanzania and Kenya kind of giving budget to giving more money for bottom-up approaches. We've got, the government says that there's no money, but we've got this, alcohol and tobacco tax that is, comes into government, and it's our poorest areas that are affected by these challenges. So, I mean, imagine if that money could be used to fund social workers. You don't need many, you just need a few social workers that can facilitate interactions between communities. And really what we need is a all hands on deck approach. I mean, we've got people with different skill sets, teachers, lawyers, entrepreneurs, that have come up in life from different population groups. They say that you are the sum total of the 10 people you most commonly interact with. So, our people in our impoverished areas, all the people that they know are people that are similarly impoverished, and that is the people that they interact with. So, whereas people that are living in other areas, they're in contact with lawyers, entrepreneurs, and scientists. They've got a bigger skill set of people to learn from. So imagine we could get people from different areas together and get them to interact on a weekly basis. What could potentially happen? We actually have a pilot project that's happening here in Cape Town at the moment, and we are seeing some changes on the ground. And I'm sure that people in this room here, in this virtual room, can speak of other case studies of where things are working. So, I mean, I think part of the thing is that, we need to have movements for change. We often speak in an echo chamber of rhetoric of where we speak about bottom-up approaches, and some of us are doing things in different spaces. But if we think back to, how did we change things around HIV? How was it that, from moving from where it was thought that ARVs could not, there used to be headlines in the Western newspapers that Africans can't take ARVs, they can't, adhere to ARVs. And we showed them in our studies that we could actually achieve better adherence rates than other countries. And now we have, universal access to ARVs, and that came about through a change movement, an advocacy movement, So similarly, I think that for bottom-up approaches, we need to have movements for change, Ubuntu movements, I think, that facilitate change. And I want to congratulate the PHASA, leadership for having set up the series of talks. I think it's something we need to consider having more regularly, where people can perhaps share case studies of what they are doing in communities, and we can learn lessons from each other, and we can perhaps, suggest ideas to each other. But really, it's about, I think, creating movements of change. We are at, I think, was it the yesterday speaker that spoke about Nelson Mandela? He spoke about, as soon as we climb one hill, we find that there are many other hills left to climb. And so, we've tackled with the policy aspect of apartheid, the real kind of nuts and bolts effect of apartheid is something that we are still grappling with. And so I really think that, the anti-apartheid movement is something that seems to have fizzled out, after 1994. I think it's more than apartheid, it's about anti-equity or inequities. And that is something that we need to look at. How can we revisit that? How can we reinvigorate that? And I think that the public health kind of space, because we see the effects through our research, we have an obligation to be leading in this process in some or other way.
Thank you very much. I think you have thrown in a very important issue of a racial dimension to inequities, which are very, very visible, especially in a country like South Africa, but also globally. You have those racial dynamics impacting on healthcare provision. But I would like to ask Aurea to come in, and if there is no any other hand, I will then move off from the participants to closing remarks by the panelists. But Aurea, please come in.
Good morning, everyone. My name is Dr. Aurea Ramatsui. I come from the Sefako Makato Health Sciences University. I'm a postdoc research fellow. I just wanted to make a few comments and thank everyone for the contributions to make us think differently. The first one that really is for me that's an issue is the issue of access. For example, when you think about our hospitals in the townships, clinics, people have an issue with access, and which is a human right issue that I think Tshoaedi talked about as well as a right. People queue from 5 a.m. to get access, and they stay in hospitals just to get treatment or follow-ups, and that alone I think is problematic. And yesterday, I think our main speaker was mentioning that TB patients do not follow through, do not finish their treatments, but if they have to, maybe let's say, come and queue for hours, some are not able to. So those are some of the problems that I think are issues. So, and again, it's something that we should not, we've normalized things that are not normal, where people have to queue from 4 a.m. or 5 a.m. to access. And I don't think it happens everywhere. As we know, it happens in some areas and not others. Some of the things as well, why don't we share good practices, maybe as managers as well of those centers and leaders? So I'm sure there is something that can be done, and we can also look in the area of technology and using AI. Most people have got cell phones. we can also give information or access patients through those kind of things. And then young people are developing apps, which I don't think the health sector is ready to use technology, which is the one that can help us really for people to better access to better health. So I also like Mohammed's view on Ubuntu. I'm also exploring in that area of Ubuntu approach to health, because in that way we would know that a person queuing for 5 hours to access health is not normal, because as I am, as we say, so we are all equal. No one should be able to do that. So I just like to, I just wanted to say all those kind of things. And then lastly, just to say, there are doctors who were striking recently and they want jobs, but at the same time, there are no doctors in hospitals. So what is really happening here in terms of governance, management, and leadership? So I just wanted to say that. Thank you very much.
Thank you very much. I'm sure that we could have explored more. The issue which you have touched, Aurea, on technology, especially in public health, it is acceptable that this would be a game changer. But I really don't know why it seems to be like a mirage in the public. I mean, we have spoken, the government has spoken, I don't know how many years ago, about TS.net, but people still go to facilities and spend a long time trying for them to look for files, manual files. I do know, for instance, that I think it was over 25 years ago, I was sitting on the provincial tender board of Limpopo government. We rolled out technology to all the hospitals, paid millions of rands. It never worked. It was water, down the drain. Somehow it couldn't work. I still don't figure out. No, I was sitting on the tender board. I know we did all the right things of procurement and so on, and someone was paid for it. But 2-3 years down the line, there was nothing operational. And I think that is one of the issues that can make sure that services are available, and quality services. And I think Mukhari touched about that as well. It has to do with technology, the extent to which strategic information is captured to all role players, not only to health professionals in hospital settings, but whoever is making a contribution. We should all be able to capture that information and understand more the impact and contribution of each. So I can see that our time is really moving very fast. We have got 2 minutes, which means that every panelist has about, 8 minutes, 2 minutes each per panelist to round off. I'm not going to now call upon you panelists. You just raise your hand and jump in when you are ready. If you are not ready, if you don't want to say anything, well and good. So can I monitor your hands, panelists? Who wants to go first? Just your concluding remarks. Natisha, you have your 2 minutes.
Thank you, Reverend. Previously, we spoke about the bottoms-up approach in detail. We spoke about giving communities a voice, building capacity, and looking at things through a empowerment lens. I just want to add to the fact that And we spoke about structural barriers as well. It's about creating safe spaces for dialogues. There needs to be inclusive dialogues between communities and decision makers where all voices, are heard and obviously respected. And they shouldn't feel that, because decision makers are in the same space, that they don't or are unable to express their views and raise any kind of concerns that they may have. The other is about promoting accountability and transparency and holding decision makers accountable for ensuring that the voices of the community are heard and considered as part of the decision-making process. And the other is about learning and adaptation. And I think somebody did touch on it. It is about willing to adapt the strategies and practices based on the evolving needs of a community, and that's very important, and as part of the community's priorities as well. And also sustaining a commitment is that invest in long-term relationships, and as one of the panelists said earlier, it's about co-creating, co-working, co-collaboration, and actioning of processes that will enable communities to speak for them effectively over time. So I just wanted to add that to the bottoms-up approach. Thanks.
Thank you. Anam, Nyembezi.
Yes, I think for me, we should also consider the competencies of our health professionals. And we should encourage them to continue with their learning and learn from others as well, learn from different people and approaches, and that we can promote and say that they should be able to enable change in the communities that they work, and then they can be able to be the advocate for health. And we spoke about issues of resources that they should be able to understand and mediate through partnerships in terms of if the resources are limited, and even when there are some conflicting ideas in terms of how to deal with certain issues. So they should be the mediators, and also they should also provide information. They should communicate to the communities that they work in. So we should make sure that they have those competencies of leadership, and also more importantly is issues of making sure that in their leadership skills they can be able to assess the needs of the community, plan in terms of the interventions that need to be implemented, and implement them in a way that they are effective in collaboration with other partners, and also make sure that they evaluate and monitor the implementation of those services. And that to me will be some of the competences that we should also look into terms of making sure that we have ethical values that are strong in terms of promoting the health of the people and dealing with issues of inequity. Thanks.
We go to Tsenolo.
Thanks, Chair. I'm also going to stay off camera. We have a power outage here, so I think my network is not very stable. Yeah, I think just appreciation for the space to share insights from this perspective of legal empowerment or community-led legal empowerment. I think just from my side, I do think that the public healthcare sector, like I said, has a very unique position in terms of using the expertise and the information that are there to begin advocating for systematic change, particularly as it relates to financing of community interventions, but also sustainability practices that are going to ensure that these organizations that are working in communities are in a position to actually continue partnering with healthcare professionals and communities. Yeah, but I think more than anything, just reiterating that point about possibly having a shadow report that is highlighting where South Africa is in relation to SDG 3 on good health and well-being. And I think that the colleagues that are here on the call today have really raised very important aspects of where we are not actually working towards a sustainable development of our public health services. So yeah, I think more than anything, it was just to share that last point, but thank you very much for the opportunity to speak.
Thank you. The last one will be Harsha.
Hi, thank you, Reverend.
Close the session.
So I think just quick reflections from me. I think there's intersections between democracy, governance, and public health are quite important, and we need to really put more priority attention on them if we're going to achieve our goals for health equity. I think the two strategic elements that stood out for me was really looking at health in all policies and people at the center of all policies, health and non-health policies as well. I think if we can get that right from a policy level all through the implementation level and on the ground, we will really do well in improving health equity. And I also want to thank everyone, all the participants, for their great engagement today. And I think it was mentioned before that these spaces are really valuable to really connect and see how we can take things forward. And so I want to thank Takalani from the PHASA board for really being the brains behind the spaces this week. And then finally, Reverend, I want to thank you because you've done such a great job in really facilitating a very rich discussion under challenging circumstances. So thank you so much.
Thank you, everyone. Thank you, everyone. It was my pleasure to facilitate the session. I have experienced during the past 2 hours a real bottom-up approach in action. Thank you. Go well.
Thank you.
Thank you, Reverend.
Thanks. Bye.